in a lot of ways we do have a great health system. So I just wanted to say that first to set the context. We are starting internationally from a high base, but what I hope we would all like to do is try and improve on that. So what I'd like to talk about today is just give a very brief overview of the health system, talk about the role of the private sector in Australia and internationally, make a few sort of clarifications and definitional issues, and then highlight some key problem areas where I think the private sector does cause some problems within our health system, focus on some rural and regional issues, and then discuss some strategies that maybe we can discuss afterwards about what I think would help address some of those issues. So the first point I'd like to make is, as Rebecca said, our health system overall is pretty good by international standards. That doesn't mean it can't be better, obviously, and no country has a health system which, you know, is without fault. But the Commonwealth Fund, which does an annual analysis of health systems across a whole range of countries, ranked Australia's second against a whole heap of criteria. But one area that we did fall down was in equity. So while we ranked second overall, first for efficiency and healthcare outcomes, we ranked 7 out of 11 countries in relation to equity. So that is one of the key deficits of our health systems. So something that I think we should be focusing on when we're looking at policy reforms. And of course, some of the groups, as you would know, that are impacted by that in particular are groups that are disadvantaged in other areas. So in particular, Aboriginal and Torres Strait Islanders, who have a much lower life expectancy than other Australians, people from disadvantaged socioeconomic backgrounds, people with mental illnesses, people from rural and regional areas, all have poorer outcomes than the general population. And here's just a graph to demonstrate that in relation to Australians living in regional, rural and remote areas. And as you can see from this, there's a clear gradient as you move from major cities out to remote and very remote areas, that avoidable deaths will increase. And rural and remote Australians do experience poorer health outcomes across the whole spectrum, but obviously avoidable deaths is a pretty clear marker and a reflection of poorer health throughout the lifespan and across a whole lot of different domains. That's from AIHW. Oh, no, I can't seem to. Here we go. So I just wanted to give a little bit of an international comparison here. So this is a graph that just shows the sources of funding for health systems across the OECD. So it breaks it down by private, public and out of pocket. And I just wanted to make the point here is that pretty much every health system, almost all health systems in the world, and certainly all in developed countries, have a substantial private sector. And as you can see from that graph there, Australia's private sector, that's the orange bar, is slightly larger than average, but it's certainly not out of step with most of the other countries there in that graph. Obviously, the US, far over to the right, is a big outlier. So the general pattern across all those countries is that the public sector contributes most of the funding, and then there's some additions from the private sector and for out of pocket costs. So I'd also make the point that private sector involvement in healthcare predates Medicare in our public health system. The private medical system, was the first health system in Australia. Private health funds predate Medicare by, 150 odd years. It's a very entrenched part of our health system. So I think, we accept that the private sector involvement is not going anywhere in the health system. It's an entrenched and enduring part of our health system. So I think the challenge is to how to make it work and to maximise the benefits and minimise some of the adverse impacts of it. And the other point I'd just like to make is how enmeshed the private and public health systems are. So the media and sometimes in discussion we talk about a private health sector and a public health sector, but that I think is a myth. In almost all areas there is both private and public sector involvement. And this chart, this wheel shows that if you look around in that middle band, which shows all the different sectors of the health system, whether it's public hospitals, private hospitals, medical services, medications, dental, and you look around the outside, which shows the source of funding, almost every area of the health system has both public and private, and often out-of-pocket costs as well, that contributes to its funding. So almost in any area of healthcare, it's impossible to separate out the public and the private health system. I'd also think it's important to make a distinction between funding and service delivery. When we talk about private healthcare and public healthcare, we can either talk about how the service is funded from a public source or how it's delivered, whether from a public or private source. And you can have both funding and service delivery being public, and this is the little table I've got here. So if you look at funding on the left and service delivery up the top, you would see a public hospital would be both public delivery, as in the service is delivered by a public service, and it's also funded publicly largely. Say a bulk bill general practice would be funded through public funds, but it would be privately delivered. Mostly privately funded service might be something like private dentistry, which is also privately delivered. So that would be in the bottom right square there. And there are even examples, though this is much smaller, of services which are publicly delivered but privately funded. And that might be something like a surgical robot in a public hospital that has been funded through either a company who funds it itself and allows the hospital to use it, or through some sort of philanthropic arrangement. So I think that distinction is crucial, whether you're talking about funding or service delivery, and that makes a difference to some of the issues that are involved, and also what some of the policy solutions might be to any problems that arise. You get different problems and different solutions for public and private funding and public and private service delivery. And just to illustrate how complex that system is and how enmeshed they are, I'm just giving a very brief example of somebody going for say something like a knee replacement, which would be a very common surgical procedure, to give you an example of all the different services and funding arrangements that they might encounter in their journey through the health system. So from a GP consultation, which would involve both public funding via Medicare and private if there's a co-payment, and the service delivery is obviously private. If the GP then refers the patient to a specialist, that again would probably be a private if it's a specialist in private practice. The funding would come both from public sources via Medicare and the publicly funded component of private health insurance, and also from private sources, so the other part of private health insurance and any co-payment. If the patient then went to a public hospital, in fact, they would then receive service from a public service, and the funding might include both public and private funding. If, for example, they used a privately funded, robot to do the surgery, as we discussed earlier. Post-surgery, they might have medication, which could involve, again, private provision by a pharmacist and publicly funded via the PBS, but also private if there's a co-payment. And rehabilitation services might also be privately provided and are likely to be funded if the person has private health insurance through partly publicly through the publicly funded rebate for private health insurance, and also through any private component. So as you can see from that, just from even, and this is probably a very simplistic model because there are probably more services involved and more intersections with different parts of the health system, but even that very simple example just shows you how many different sources of funding and service provision that person will encounter, and that is typical for someone getting care in the health system. So I just thought I'd highlight three three problem areas that I think privatisation or private sector involvement in the health system, and three sort of pain points where I think where it's not working. There are probably examples of where it does work, but these are areas which I think are really overdue for some attention and are causing problem. And one of those is out-of-pocket costs. So out-of-pocket costs, I think, are a big problem in our health system. They incur mostly for private services, not entirely. It's not only to do with privatisation, but it is largely to do with privately provided health services. Out-of-pocket costs, and here is an example of how substantial they can be. This is a survey that was undertaken by the Consumers Health Forum. And as you can see there are a number of people that reported incurring more than $10,000 in out-of-pocket costs over the past 2 years. So the problem with out-of-pocket costs is obviously that they can be very substantial in those cases, and there are examples of people incurring extremely large bills. They're also a problem in that they really impact inequitably over the population. So people who are poor incur higher out-of-pocket costs as a proportion of their income, so they're much less affordable, have a much bigger impact on them. And obviously they impact a lot more on people who are sick rather than people who are well. So unlike a public universal system such as Medicare, which will people contribute on the basis of their ability. They contribute by their tax, so they pay more the more they earn, and they receive the benefits when they need them. The out-of-pocket costs act almost in the opposite of that. You know, that the less able you are to afford them, the more impact they're going to have. Private health insurance, I think, is another pain point within our health system, and private health insurance is the funding mechanism for much of the private health sector, in particular private hospitals, and also obviously dental and allied health. The problems with private health insurance are very structural, so it's partly to do with the way it has been set up and the introduction of Medicare on top of private health insurance. And the tensions that are involved in having a private funding mechanism alongside a public universal system, and those tensions were never addressed, and the relationship between them to make those two systems work together were never really resolved when Medicare was introduced in 1983, 1984. And those sort of structural problems are still causing problems today. So we have seen, declining numbers of people with private health insurance. We've seen government putting more and more money and implementing changes to try and keep those numbers rising. We've seen it enter what's been, called a death spiral, with people sort of dropping their cover, which then, the people that drop their cover tend to be people at lower risk, which then leaves the insured pool of people with higher risk, which then pushes premiums up, which then causes more people to leave. As premiums rise, they then tend to be the lower risk people that are left, and then you enter this sort of cycle. No government has really wanted to take on the challenge of having to reform that area to really look at whether there is a role for private health insurance alongside Medicare, and if so, what that role should be. John Howard in 1998 made the decision to fund 30% of premiums and introduce the private health insurance rebate, which is costing, increasingly more every year as premiums rise. And, the sort of cycle that has continued is something that is, a major area of sort of policy dissonance, and no government is really seeing a way out beyond that. Each government that gets in will just try and sort of paper over the cracks and try and make it limp along till the next election, and then hope they won't have to deal with it. And the third area is one that everything would be aware of at the moment, is the problems with aged care. Aged care has been increasingly, privatised over the past sort of 10, 20 years since the 1990s. Aged care is largely publicly funded, but delivered mostly through private providers. And as we've seen in the current coronavirus pandemic, the problems that this has resulted in terms of, you know, quality and infection control, and the problems there, and the inability of the government to oversight that. And these are all problems that were well documented before. They're nothing new, but obviously they are even more serious in the current environment. And that is, I would argue, largely a result not just of privatisation, but of privatisation, you know, poor funding, and the lack of an effective approach by governments to managing that transition to privatisation within that sector. So I just wanted to also give an example, focusing in particular on rural and regional areas, and just show how the intersection of privatisation with other issues can impact then upon consumers. Most of the problems that are related to privatisation, in my experience, are not just because of privatisation per se. There's sort of the intersection of privatisation with other issues. So this is one, I think, that makes it very clear about the impact of access to allied health for people in rural and remote areas. So this is a graph that shows how many of these key professions, pharmacists, physios, psychologists, and optometrists, and the clear gradient as you go from MC as major cities, IR is inner regional, ORs are outer regional, R is remote, and VR is very remote. So basically, and this is numbers per 100 population, so not absolute numbers, obviously. I mean, through 100,000 population, not absolute numbers. So clearly, as you go from a major city out to a very remote area, you see a steady decline in the numbers of these very important allied professions per head of population, which of course means reduced access for consumers. And part of the reason this is a privatisation issue is because most of these professions are in private practice. So we don't have a big public sector allied health workforce. That's not part of our health system. Most allied health is provided through private practice. That means the government has very limited levers to encourage these professions to work in rural and remote areas, which then leads to them choosing to work mostly in cities, leads to workforce shortages in those areas and reduced access for consumers. Another area is private hospitals. And again, private hospitals provide, you know, a lot of very important services. They do, you know, they do the majority of elective surgery. They provide really important services like rehabilitation. But the model of private hospitals, clearly, particularly for-profit hospitals, is that they work based on large numbers. They have a business model that relies on you know, having patient throughput, and this is an efficient way to do much of the services that they do. There is nothing wrong with that in itself, but it does mean that it's not profitable for them to set up in areas where they can't get that patient throughput. And this is an example here of Ramsay Health, which is the largest provider of private hospitals in Australia, and this is the only two hospitals they have in WA. So as you can see, you know, the vast majority of the state is not covered by their services. And again, private health insurance, as we discussed before, the numbers of people with private health insurance declines as you move out from major cities. And this is an issue. It's obviously an equity issue because people in rural and regional Australia pay through their taxes to support private health insurance through the 30% rebate. So even the people that living in those areas who don't have private health insurance are paying for it through their taxes. People in those areas who do have private health insurance pay the same premiums as those in the city, but have reduced access because the services aren't as available to them. So they receive less benefit for their insurance than people living in cities. So I'll just briefly just go through these. I'll just be really quick so we can, I can get your views on them, which will be more interesting than hearing me talk about them. These are just 6 strategies that I think would help address some of these issues. So firstly, I think we need to have a community debate about privatisation. A lot of the changes in our health system and the role of the private sector has never been discussed or debated. It's just been introduced basically by various governments over the years without that broader debate. And we can see recently some of the discomfort expressed in the media about for-profit aged care providers, about the money that they made, the cars that they own, their lifestyle. And there was a degree of discomfort that people were dying in aged care facilities from coronavirus, not being able to access PPE for the staff, where their owners had a lavish lifestyle allegedly. So there's obviously some community discomfort around that needs to be talked about. We need an overarching policy on out-of-pocket costs across the whole spectrum of the health system that looks at how much we think is reasonable for people to contribute to their healthcare out of their own pocket, and how much we should be sharing our costs through, Medicare or some other mechanism, not just service by service, but over the whole course of someone's experience of the health system and the care they need. We need to get much better at monitoring and setting up good governance processes for private health services. So often the failures that we see in quality, like in the aged care area, is because governments are not skilled and don't have the people and the experience needed to set up really robust, comprehensive monitoring systems to make sure that checks and balances are in place, so private health services can deliver the quality that people deserve. I think we also need a comprehensive inquiry into the private health sector. Some of you may remember that before the last election, this was proposed by Labor, a productivity commission inquiry, and there's a lot of support for that around the health sector. So we could have a really good look at what we want the private health sector in Australia, or private health involvement, private sector involvement in healthcare, what we want that to deliver, and to have all stakeholders involved in that debate. And I think 2 key things to support that are improved data. There are a lot of areas of private health service provision in particular, which we don't have really good data. So we need good data, and we need it to be linked up together so we can really look at what's being delivered by private health services, what outcomes they have, and we can really measure their outcome and know what their value is, so then we can then fund them accordingly. And I think finally the most important thing is really consumer empowerment. So we have a health system that's really run around providers' interests and is centred around providers. Unfortunately, providers and the medical profession and health industries have much more impact on the health system than consumers. And I think until that changes, we won't get the sort of reforms we need that will address some of those issues and deliver a health system that's really centred around consumers' interests and improve some of the problems with equity that we've discussed. So I just also leave you with just some suggestions. If these are not sources that you're familiar with, these are some of the sources which I think are really useful to cover some of these issues. And if you're interested in finding out a bit more, they're really good places to go to with people writing and discussing some of those issues that I've talked about. So there we go.